State may call its next witness.
Thank you, Your Honor. The state calls Nicole McKenzie.
Raise your right hand. You swear or affirm under penalty of perjury that the testimony you're about to give will be the truth, that nothing but the truth.
Yes, Your Honor.
Proceed. And if you feel comfortable doing so, we prefer that you take your mask off.
Certainly.
And before you begin, actually, could you grab me that stylus that's there? Thank you. Now we'll get going for you.
Oh.
If you could begin by giving us your full name, spelling each of your names.
Nicole McKenzie, Nicole. Last name McKenzie, Mackenzie.
Mr. Slisher.
Good afternoon.
Good afternoon.
How are you employed?
I'm employed by the Minneapolis Police Department.
How long have you been employed by the police department?
About 6 years.
And what is your current role there?
I am a police officer.
Do you have a specific duty assignment?
I do. I am the medical support coordinator for the department.
All right. Now, before we talk about that role, I'd like you to share a little bit about yourself with the jury. How long then have you been a police officer or in law enforcement?
I've been in law enforcement for about 6 years, all of that whole time with the Minneapolis Police Department.
And did you have a career prior to going into law enforcement?
I did, yes. I worked in human resources.
Okay. What's your educational background?
I have an associate's degree in human resources. I have a bachelor's degree in business. I am an EMT. I also have my law enforcement certificate, and I'm also an EMR instructor.
You worked in human resources. That was your original plan?
Correct.
How long have you wanted to be a police officer?
Actually, it's something I had always wanted to do. I just kind of talked myself out of it for one way or another, but eventually found my way back.
Can you please tell the jury how you entered law enforcement? Did you go through the academy?
I did, yes. I came in as a cadet, which means that the department sponsors the education components that make you eligible for the post-exam in the state of Minnesota.
And how long of a program was that?
I think it was about 9 months total.
After you completed the in-class or the classroom portion of the academy, did you go through field training?
I did.
How long was that process?
The field training at that time was about 5.5 to 6 months.
And as an officer with the Minneapolis Police Department, are you familiar with some of the officers who also work in the department?
I am.
Are you familiar with the name Derek Chauvin?
I am.
How are you familiar with that name?
He was actually one of my fill-in FTOs for one day while I was on FTO. I think my FTO was sick, but also he's attended my training that I've conducted with the department.
All right. And would you recognize him if you saw him?
Yes.
Do you see him in the courtroom today?
Yes, sir.
Would you please point to him and describe what he's wearing?
Yep. It's the gentleman here in the light gray suit.
All right. May the record reflect the witness has identified the defendant.
Any objection? It will.
You indicated that you're the medical support coordinator. Is that right?
Yes, sir.
Could you please describe for the jury what that role entails?
Certainly. There's a couple different components to it. Primarily, it's going to be the first aid education that all of the officers receive. I do the training for the academy, both the recruits and the cadets, as well as the in-service, which is more like the continuing ed for all of the current officers. And I am also administrator of the Narcan program that we have.
What is the Narcan program?
The Narcan program is the training and administration of pharmaceutical to use to temporarily reduce opiate overdoses.
And is Narcan, is that something that officers have available to them?
Yes, sir.
Yeah. And you provide the specific training regarding the use of Narcan. Is that
I do.
right? Okay. And also you provide medical training both at the academy and in service. Is that right?
Correct.
Are you familiar with the requirements from the department and the post requirements for how often officers are supposed to train in medical procedures?
Yeah, with the Minnesota Post Board, when you're able to apply for the examination, you do have to have your EMR certification, and that's Emergency Medical Responder. Beyond that, the Post Board doesn't require anything terribly specific, but with the Minneapolis Police Department, we do continuing education every year on medical-related topics.
You said that the Post Board doesn't require anything more specific. Can you explain that?
With their education requirements as far as the continuing ed, as long as you've met the minimum number of hours, there are certain topics that they require you to complete. Other ones, because with the Minneapolis Police Department, we go above and beyond what the Post Board requires. So that's where we add in extra medical training.
And you do that every year?
We do.
Are police officers required to have a specific CPR card?
Not a card, no. You're not required to have that beyond your initial post certification.
When you're initially post certified, you need one.
Correct.
And
that's a part of the EMR certification that's required to be eligible to take the post exam.
And some officers will continue to obtain the CPR card. Is that right?
Correct.
You know what is required in order to obtain that card?
It's about a 4-hour class. There's a written test and a skills examination test out.
And what does it cover?
It includes adult CPR and AED, infant CPR AED, as well as choking.
Now, at this time, I'd like to display to the witness and not to the jury Exhibit 277 for identification. If you take a look at what's been marked for identification as Exhibit 277, does that appear to be an American Heart Association CPR AED card?
Correct, yes.
Is that the type of card that you get issued if you complete the 4-hour course you just mentioned?
Yes.
While it's not required, some officers continue them, and those cards are maintained in the records of the Minneapolis Police Department. Is that right?
If they had taken a full AHA course through the Minneapolis Police Department, we would be the record holder.
All right. And then if we can take a look at Exhibit 278, that also appeared to be a CPR card, just of a different year.
Correct.
Okay, I'm going to offer Exhibits 277 and 278.
277 and 278 are received.
If we could publish Exhibit 277 and highlight the portion. Does this appear to be a Heart Saver CPR AED card issued to Derek Chauvin, March 2012 through March 2014?
Correct.
Okay. And if we could display Exhibit 278. Again, a CPR card issued to the defendant from January 2014 to January 2016. Is that right?
That's correct.
And then when you provide the training, medical training to law enforcement officers, does that training get reported into the workforce system to be able to report to the post board?
It does.
Now, when did you start personally delivering this training?
I had been a part-time instructor since 2017, and I assumed the full-time position January of 2020.
Okay. How many times do you think that you've provided this training, this in-service training to law enforcement officers?
CPR specifically?
Yes.
I would say upwards of 20 to 30 sessions.
All right. And do you use a slide deck or a PowerPoint to do your medical presentation every year?
We do.
If I can show you Exhibit 111, just to the witness, not to the jury. Okay. Exhibit 111, do you recognize what appears to be the first part of a slide deck?
Yes.
And if we can turn to the second page of 111, does that appear to have, it says MPD CPR? Is that right?
Correct.
Have you personally delivered this slide deck before?
I have.
Approximately how many times?
This was in service of 2019, and my best estimation, this was probably carried out over the course of maybe 12 sessions or so, 12 to 15 sessions, and I was responsible for about a third of them.
Right. Did the defendant attend any of your sessions?
I'm not sure.
But you were providing the block of training that everyone consistently took back in the in-service in 2019?
Correct. I was the assistant instructor here, and I ran one of the skill stations. So theoretically, everybody from the department would have come through my skill station at some point.
Now, at this time, if I can, you can take that down here. I'm going to offer Exhibit 111.
Any objection? 111 is received.
In general terms, then, you provide the jury an overview of the specific medical training that you provide to law enforcement officers on an annual basis.
For in-service specifically?
For in-service, yes.
Okay. We do offer a wide variety of different kind of trainings, depending on how many training sessions are going to be available to us in a year. But at a minimum, every year we are touching on CPR and AED. And then in alternate years, we're also going over a refresher class on Narcan. And that's the minimum standard. If we have more training spots available to us, we can add in more classes.
And are you aware whether the Minneapolis Police Department has a specific policy regarding rendering of emergency aid?
We do.
And could you please provide the jury just a high-level overview of what that policy requires?
Certainly. It's a high-level summary of our first aid policy is going to be requesting EMS resources to anybody that needs it or anybody who requests it, and also rendering first aid that's consistent with your training that you've received.
And does the policy allow you to do one or the other? Can you just call for the ambulance and not do the emergency medical procedures?
It depends on the situation specifically. If there was really no need for immediate first aid, maybe like a small cut or abrasion, it would be then appropriate to just wait for EMS to arrive. But if it's a critical situation, no, you have to do both.
I'd like you now to kind of walk us through some of the specific training that you provide, and we'll use Exhibit 111 to do so. If you could publish Exhibit 111 starting at page 6. Well, let's go back to page 1. All right, why don't you explain page 1 of this?
Okay, so this is an image of a clip that's taken from the classic movie Dumb and Dumber. And this is a video clip that we show at the very beginning of training. It's more or less just kind of a lighthearted way to get people a little bit more engaged in the class. As
Not a substantive slide.
No, absolutely not.
All right. Now, I'd like to then cover the substantive portions. If you could go to page 6 and review the portion of the slide deck that says agenda. You please describe to the jury each of these different portions of the training that you provide.
Certainly. So this block of training was primarily focused on CPR, but we did throw in a couple of extra pieces of information because we had the time available to us. So we just kind of briefly retouched on other things we had had already taught, which was tactical combat casualty care. That's basically rendering aid for more traumatic injuries, if you will. Then we also provided an update on our Narcan program as far as usage and maybe things we had learned since we had initially rolled it out. And then the remainder of the time was focused on the full CPR course.
All right. If you could go to page 21 of Exhibit 111. And for the jury, would you please describe, and using this slide, just kind of walk us through what specific training you provide Minneapolis Police Department as it pertains to CPR?
Okay. When we're called to a scene where there is some kind of medical situation going on, maybe it's illness or injury, whatever it happens to be, we have a little bit of a mnemonic that we always kind of walk through to make sure that we're covering all the basics. So when you're encountering somebody that appears to be unconscious, we start with an acronym that's called AVPU. That's AVPU. We walk through that acronym to determine a level of responsiveness. And then we kind of work through the A, B's, and C's, which is airway, breathing, and circulation.
Right. I'd like you to then please go to the next page, 22. AVPU, could you please walk the jury through this assessment tool?
Certainly. So when you're determining somebody's level of responsiveness, you kind of walk through this as your model to see where they land. So if somebody's alert, that means that, you know, as soon as I walk into the room, like, and they spontaneously look at me, I determine, okay, that person's alert. I don't really need to go any further. Verbal would be, you know, maybe just kind of yelling towards somebody or trying to get their attention, something like that, to see if they respond to any verbal stimuli. And if you don't get a response there, then you move on to the P, which is pain. And that's going to be like something like, for instance, you know, if you grab like the base of the fingernail and kind of press against it, you're just kind of looking for any kind of like response that somebody would like normally like pull away from. We're certainly not talking about anything that would, you know, cause any injury per se, but just a little pain stimulus, see if they kind of pull away from you or something like that. And if they don't respond, then you determine that person is unresponsive.
I'd like to just talk about, have you talk about the P, the painful stimuli, briefly. It sounds like in the assessment tool, what the person is doing, the trainee is doing, is going to be applying a painful stimulus to see if the person reacts. Is that right?
That's correct.
Is it possible to determine someone's level of responsiveness without intentionally, or should I say, without inflicting pain for the purpose of checking stimuli? So, for example, just observing whether the person is continuing to react to some kind of painful stimulus.
Can you rephrase that?
Sure. If someone, if you came upon an individual who was injured, for example, and crying out or manifesting some sort of pain as a result of the injury, but at some point they stop being verbal, they stop responding to that pain, could that potentially be a sign of non-responsiveness?
Correct, yes.
Once you determine an individual is unresponsive, then what do you do?
Then you walk through the next set of acronyms, which is going to be your A, B's, and C's.
If you could return to page 21, please. Okay. And the A, B's, and C's, that's airway, breathing, and circulation. Is that
That's
right?
correct.
Okay. And if you could go to page 23. Can you please describe to the jury then what you train officers to do based on this slide within Exhibit 111?
Certainly. After you've determined their level of responsiveness, if they're unresponsive, you're going to first address their airway, and that means just putting them in the most ideal physical position where their airway can be as most in line as possible.
And then what's the next step?
Tilting up the head slightly to open up their whether you use a head tilt chin lift or a jaw thrust maneuver to open up their airway.
Okay.
And then the next step beyond that is moving into checking for breathing. And if you don't see chest rise, it's just a matter of putting a hand on the center of the chest and, you know, seeing if there's any kind of air moving up and down.
Right. And then what's the next step?
The last is circulation. So that's where we're going to be checking a carotid pulse right up here underneath the jaw.
Are there other places that officers are trained that they can use to check for a pulse aside from the carotid?
Yep, absolutely. You can, you know, use your radial here at your wrist. There's multiple points on your body where you can check them, but this is by far and away the most important.
And what are officers trained to do if they are unable to find a pulse?
If you don't have a pulse on a person, you'll immediately start CPR.
Now, I want to go back to the concept of checking for breathing. You indicated that you can look for the chest rising and falling. Is that right?
Mm-hmm. Yes. Yes.
All right. Do you train officers that as part of your training, you train officers that if a person can talk, means that they can breathe?
No, sir.
Okay. Why not?
Well, that would be incomplete to say, because there is a possibility that somebody could be in respiratory distress and still being able to verbalize it. Just because they're speaking doesn't mean they're breathing adequately.
All right. And getting back to circulation, you indicated that if the officer cannot find a pulse, they're to start CPR. Is that
Yes, sir.
correct? And describe what is done to start CPR.
So to start CPR, if you're going to be starting that, if you haven't already contacted EMS to get them en route, you would do that immediately. Then it's a matter of just interlocking your fingers, and you go to the center of the chest, and then you push down about a third of the depth on that person at the rate of about 100 beats per minute.
And is this something, that, again, getting back to the MPD policy, that the officer is trained that they're required to do while they're waiting for the ambulance?
Yes.
And when is the officer supposed to stop CPR?
When you've been relieved by somebody with a higher level of training than you, or if there was some obvious signs of death, or if you've been doing it for a while, if you're absolutely just physically exhausted from doing CPR.
If you could display page 27 of the exhibit. Right. And officers are specifically trained on this, is that right?
Correct.
It can be when the subject becomes responsive or wakes up,
Right.
or someone else takes over, or as you stated, it's not safe or you physically can't do it anymore. Is that
Correct.
right?
Yes.
Okay. And is this consistent then with the training that you provide every year to each and every law enforcement officer who is recorded as having taken this training during in-service?
Yes.
All right, I have nothing further. Thank you, Your Honor.
Mr. Nelson. You may. You may.
Sorry about that. Thank you, Your Honor. Sorry about that, ma'am.
No worries.
My glasses. All right, I think I'm ready now. Thank you for joining us today. Just a few follow-up questions. You have been with the Minneapolis Police Department for about 6 years at this point?
Correct.
And prior to that, you said you were an EMT as well, right?
Correct.
Now, as far as the Minneapolis Police Department is concerned, there are officers are trained as essentially first responders, correct?
Correct, with the EMR certification.
Right, emergency.
Medical responder.
And so it's sort of it's a lower level of medical training, correct?
Then an EMT, that is correct.
Right. So you may go to a CPR class, then you have your first responder, and then an EMT paramedic, correct?
That would be a natural progression, yeah.
Right. And so you have experience, did you work as an EMT as well as?
I did.
Okay. And so you have experience both as a police officer as well as an EMT, correct?
Correct.
Now, you testified that part of your role now as running the medical program is to present officers with information as to multiple medical issues that they may encounter.
Correct.
It's not just limited to first aid or first responder, CPR type stuff, correct?
No, we also teach like wellness classes, whether it's sleep, nutrition. We have a wide variety of classes.
Okay. And you have classes on topics including excited delirium?
Correct.
And you have topics including the administration of Narcan?
Correct.
And officers, are all Minneapolis police officers permitted to carry Narcan, assuming they've had the training?
Yes.
And do all Minneapolis police officers receive that training?
Yes.
And so some of these medical topics at these continuing education classes, they may come up an hour here or a half hour there during an in-service, right?
Depends on the topic, yes.
Right. So the EMR stuff is kind of a standalone class. There may be, that's a longer class, right?
Correct. That's basically your initial medical training, as you're required to get as your post certification. That's about a 40-hour class.
Okay. And then you'll have refresher classes on that stuff as well, correct?
It'll contain many of the same topics, but the Minneapolis Police Department doesn't require officers to keep their EMR certification.
Okay. All right. And so the certification that we saw Mr. Chauvin had expiring in 2016, I believe,
That was CPR.
the CPR.
Yep.
And are officers required to then have CPR every 2 years after that?
Yeah, we do CPR classes on a rotating basis, so every other year they go through CPR.
All right. Now, I would like to talk to you about a couple of the Minneapolis policies, if we could. So there's essentially two Minneapolis police policies that deal with emergency medical response, correct?
Correct.
One being after a use of force, correct?
That is correct.
And that being as soon as reasonably practical, determine if anyone was injured and render medical aid consistent with training and request EMS if necessary, correct?
Correct.
That's policy 5-306 involving a use of force, correct?
Yes, sir.
And so the policy is somewhat qualified, correct? Meaning it's as soon as reasonably practical, correct?
Correct.
So in the course of the medical training, one of the things that you train officers to do in the administration of first aid is to consider other circumstances, right?
Correct. You would have to make sure that your scene is safe before you're able to render aid.
Right. And there's the scene being safe could be, not being safe could be come from a number of factors, correct?
Absolutely.
Environmental factors such as where you're located, right?
Yes.
Whether there's a lot of traffic, correct?
Yes.
Or whether there's a lot of bystanders, correct?
Correct.
Depending on their behavior, right?
Yes.
Okay. So scene safety is important, and in fact, Minneapolis police or the EMTs won't come to a scene until it's declared code 4 generally, correct?
Generally, yes.
And so oftentimes it's not uncommon for EMTs to stage off-site until police call a scene code 4, correct?
Correct.
Code 4 being all clear, all safe, come on in.
Yes.
And so in that situation, if a scene is unsafe, EMTs don't come in at that point,
Correct.
right? The other policy that we deal with here too many things open here. Is policy, Minneapolis Police Policy 7-350. That's in front of you right now.
It is.
And again, instant or relative to the emergency medical response, Minneapolis police officers are required to request EMS as soon as practical, correct?
Correct.
And so there may be certain things that prevent an officer from calling in EMS, right?
Absolutely.
So both of the medical policies are somewhat qualified or contingent upon what's going on at the scene at the time, right?
Yes.
Now, in terms of, I believe it was this, Exhibit 111, which is the CPR presentation that you've presented, turn to I'm going to turn to Bates 21856 down at the bottom there. There is a reference to agonal breathing.
Yes.
What is agonal breathing?
Agonal breathing is something you'll see in somebody who's unresponsive and they're in some sort of respiratory distress. We see this quite often with opiate overdoses, medical emergencies, drownings, what have you.
And can you describe what exactly agonal breathing is?
Well, by name, it's kind of a bad term for it because it's not effective breathing. It's more or less kind of an irregular gasp for air.
Okay.
It's really just kind of like your brain's last ditch effort to try to pull some air in.
And a person observing someone going through agonal breathing, it's common, or it would be possible that they would misinterpret that as actual breathing, effective breathing.
Yes, it can be easily confused with real breathing, so that's why we teach this is not effective breathing.
Right. So an officer is dealing with someone who's experiencing agonal breathing. It would potentially be possible for an officer to misinterpret agonal breathing for effective breathing.
It could.
And in certain circumstances where there's a lot of noise or a lot of commotion, would it be more likely that that could happen?
Yes.
Now, you were shown this slide in terms of when do we stop CPR, and one of the reasons you stop performing CPR is because it's not safe, right?
Correct.
And by it being not safe, are you referring to the process of actually giving CPR or the environment that you would be doing it in?
It would be the environment around you.
Okay. And so it stands to reason that if the environment around you you would determine to be not safe, you may not start it right away.
That would be reasonable, yes.
Now, you also testified that you teach on Narcan and the use of Narcan.
Correct.
And I am going to show you. You can see this training in front of you.
Yes.
Is this training that you provide to Minneapolis police officers?
Yes.
And this is the this is the program on like the broader course on how to administer Narcan, correct?
Correct.
And do you recognize this as a record that you keep in the ordinary course of your business?
Yes, sir.
This, Mr. Slisher, I had labeled as Exhibit 1041. And I would move to admit Exhibit 1041.
No objection.
1041 is received.
I don't know why it's doing this. Here we go. And permission to publish 1041. This is from the Minneapolis Police Department in service from July of 2018.
Correct.
And if Mr. Chauvin had attended this program and or his in-service in July or through September of 2018, he would have received this training, correct?
Correct.
Now, in recent years, fentanyl has become more of a concern for officers to be aware of, correct?
Absolutely.
And ultimately, you train officers in the use of Narcan to contraindicate, or to contradict, I should say, the effects of Narcan, right? Oh, excuse me,
effect of opiates, yes.
including fentanyl.
Correct.
Right? Now, in your experience as a police officer and as a medical trainer, have you experienced individuals who take combinations of drugs?
Yes,
Have you heard the term speedball?
I have.
And would you agree that that is generally the combination of both a stimulant like methamphetamine and a depressant like fentanyl?
Yes.
And
Objection, sidebar, Your Honor.
can you describe for the jury what a speedball is?
It's essentially a combination of an upper and a downer.
And has that become commonplace in your experience?
Yes.
Now, as fentanyl has become more prominent, do you see that in legal forms, such as patches or other pills that may be administered by a hospital?
Objection leading.
Overruled.
Do you see that on the streets?
Yes, you'll see totally legitimate pharmaceutical purposes, and then also illicit, drugs that were manufactured
Sure.
outside of lines.
Can you explain for the jury whether, in your experience, you've seen illicit fentanyl use on the rise?
Yes,
Becoming more
absolutely.
And I'm going to just show you, generally when you talk about someone, you show it to officers in this training, when someone is on the experiencing an opiate overdose, you may see this type of behavior. Is that correct?
You could, yes.
Someone may fall asleep, someone may be very tired, kind of out of it, right?
Correct.
Objection leading.
Yeah, let's get back to the right question.
Sorry. Would this be consistent with what you would see generally on a opiate overdose?
It could be.
Have you ever been at a scene where an opiate overdose, someone can be more responsive,
Yes,
even though they've taken an opiate?
correct.
Now, in terms of fentanyl, can you explain this slide?
Certainly. So this is a diagram to show you just what could be considered a lethal dose of fentanyl. Just it's more of a visual indicator because we already know how dangerous heroin is, and you can see a trace amount of that could be deadly with fentanyl, and even more so with carfentanil.
And so even fentanyl, even in very small doses, can be fatal. Would that be accurate?
Objection, Your Honor. Sidebar.
I'll rephrase the question.
Persist in the objection, Your Honor.
Okay, second.
So these are the training materials that you present to Minneapolis police officers relevant to the use of Narcan and controlled substances that they may encounter while in their performance of their duties, correct?
Correct.
All right. Now, in terms of, and we can take this down, in terms of just again general training, you'd already said that you also discuss with officers the concepts of excited delirium, correct?
Correct.
And you provide them with training and materials about what that means, correct?
Yes.
All right. And generally speaking, without reviewing to your training materials, can you describe what you train Minneapolis police officers about excited delirium?
Certainly. And this is a class that is taught at the academy. It's a 1 hour block of 1 hour block of instruction to recognize the signs and symptoms of excited delirium and your best responses for handling that. So excited delirium, it's a combination of psychomotor agitation, psychosis, hypothermia, a wide variety of things you might see in a person or rather bizarre behavior. And recognizing that this is a medical condition, not necessarily a criminal matter.
Would that include discussion of controlled substances in the context of excited delirium?
Yes, because what we're usually teaching is that most of the people that are experiencing something like excited delirium, usually there's illicit drugs on board that might be a contributing factor.
And as far as what do you train Minneapolis police officers relevant to the physical attributes of a person experiencing excited delirium?
The person might be experiencing a hyperthermia, means elevated body temperature. That could be displayed with somebody taking off their clothes in a place it's not appropriate to take off your clothes, or in like the middle of winter or something like that. And just based on their activity, their heart rate might be extremely elevated, and they might be insensitive to pain.
How does it affect strength?
Because you don't really have that pain compliance that would normally otherwise kind of control somebody's behavior. So somebody experiencing this, they might have what we call superhuman strength. They might be able to lift things they wouldn't normally otherwise be able to lift. They might be breaking things where they then have blood like substances that you need to be cautious of.
Thank you. Now, in terms of, I'm going to just back up and talk a little bit more about the response to a medical emergency by EMS, again, based on your experience as a police officer and an EMT. You talked about how sometimes EMS will stage off site until a scene is clear and safe, correct?
Correct.
And have you heard the term load and go?
Yes.
Can you describe for the jury what that is?
Load and go, that would be, I think it's more of like an informal term that's used with first responders. That essentially means that as soon as they're going to be arriving, it's a priority to get that person into the ambulance as soon as possible and get en route to the hospital as soon as possible.
Are there reasons why an EMT would, or a paramedic would choose to do that rather than administering first aid at the scene?
Yes.
What are those reasons?
By
This goes beyond the scope of the training.
If you know. If you don't know, just
Okay.
say so.
Sure. I feel comfortable answering it. And by way of example, if maybe somebody had a knife in their chest, obviously, I mean, there's only so many things you can do for that person pre-hospital. Really, the only thing that's going to save that person is immediate surgery.
Sure. So there may be conditions of the individual that warrant that type of pick up and go?
Yeah.
And what about people in the area? Could that affect an EMT's decision to load and go?
Yes.
How so?
If you had a very hostile or volatile crowd, I know it sounds unreasonable, but bystanders do occasionally attack EMS crews. So sometimes just getting out of the situation is kind of the best way to diffuse it.
Okay. And have you ever had to perform emergency services in not even a hostile crowd, just a loud, excited crowd?
Yes.
Is that, in your experience, more or less difficult?
It's incredibly difficult.
Why?
Because if you're trying to be heads down on a patient that you need to render aid to, it's very difficult to focus on that patient while there's other things around you. If you don't feel safe around you, if you don't have enough resources, it's very difficult to focus on the one thing in front of you.
It can be distracting.
Absolutely.
And so does it make it more difficult to assess a patient?
It does.
Does it make it more likely that you may miss signs that a patient is experiencing something?
Yes.
And so the distraction can actually harm the potential care of the patient.
Yes.
I have no further questions.
Are officers trained that sometimes they have to provide emergency medical services in less than ideal conditions?
Yes.
The rendering of emergency aid in practice does not happen in a classroom setting, does it?
Correct.
Right? And so you're in the environment as you find it. Is that right?
Yes.
And in terms of a crowd, and a crowd being hostile, how would you define hostility?
That would be a growing contingent of people around. If they're, yelling, being, even verbally abusive to those that are trying to provide scene security.
Okay. What else?
If there's people trying to interfere with a crime scene or, interfere with a patient. Absolutely.
Perhaps use a weapon,
Yep.
throw rocks or bottles.
Yes.
Something like that could prevent someone from providing emergency aid. Is that right?
Absolutely.
Can the activities, though, of a crowd, the activities of a group of onlookers, excuse a police officer from the duty to render emergency medical aid to a subject who needs it?
Only if they were physically getting themselves involved, I would say.
If they were physically prevented, if the officer was physically prevented from doing it?
Yes, if the officer is being physically assaulted.
I wanted to talk a little bit about some of the things you said were indicative of excited delirium. You said superhuman strength, is that right?
Yes.
And I think what you said was that it was because of the inability to feel pain, is that right?
That's a part of it, yes.
And the inability to feel pain is something that you associate with, or you train officers to associate with excited delirium?
That it could be a case of excited delirium, yes.
And so if someone was actually manifesting a response to pain, indicating that something was hurting them, then that would tend to indicate that they're not suffering from excited delirium. Isn't that right?
Rephrase.
What would a subject's response to pain stimulus suggest then, as it relates to excited delirium?
That, well, it may or may not be excited delirium. It's a little bit hard to predict because no two people ever really present the exact same way.
So then how do you tell what it is?
Well, that's not up for us to diagnose. It's just a matter of taking in the information you have at that time to decide if this could potentially be a case of that, or you just need to plan accordingly.
And you indicated that whatever excited delirium is, you look at it as a medical issue.
Correct.
That needs treatment.
Yes.
And in terms of drug use as well, it's fair to say that if someone is showing indicia of drug intoxication, it can make them vulnerable,
Yes.
not just violent.
Correct.
Thank you. Nothing further.
Members of the jury, let's take 10 minutes. We have to deal with one issue. The witness will remain, however. So 10 minutes and we'll be back in touch. The hearing of the jury, but on the record. There was a sidebar at some point where the state objected to the excited delirium training material, and essentially, I think, Mr. Slisher, I don't want to speak for you too much, that your preference would be that Mr. Nelson not be allowed to present it at this time, but only as part of his case in chief, which would require this witness to come back during his case in chief. Is that correct?
It is.
All right, and so that's the basic objection, is the timing as opposed to the admissibility.
Yes,
Okay, Mr. Nelson, what did you want to deal with?
If we could have a private conversation.
All right. I'm going to excuse you for the day. She can be excused at this point, is that correct?
Yes.
You can be excused for the day, but the defense would like to call you back during their case. And so Mr. Nelson will serve a subpoena on you at some point so that you've got it mostly for his contact information.
Sure.
Because in the interim, I'm going to order that your subpoena that you were previously served still is in force, and that you should, unless you hear otherwise, come next Tuesday at 9 a.m. But most likely, Mr. Nelson will be in contact to tell you when exactly, so you don't just waste your time coming down here.
Yes, sir.
Does that work?
Understood. Yep.
Okay. So, Mr. Nelson, how is that going to be served?
Department?
Normally, yes.
I can just serve the police through the normal or through the federation or something?
Yeah, absolutely.
All right. We'll make sure that gets done. But for today, you're excused.
Oh,
Thank you.
Thank you.